Imagine 6 weeks from now, you wake up in the morning, sit on the edge of your bed, and for the first time in years, your body does not feel like it is fighting against you. Your legs do not feel as heavy. Your energy does not disappear before noon. Your mind feels clearer. You walk through the kitchen without that strange, dragging exhaustion that you quietly accepted as part of aging. Your blood pressure is still being monitored carefully, of course, but something feels different. Your body feels more cooperative again. And what if I told you that for some adults over 60, that change has nothing to do with a miracle supplement, an expensive biohacking program, or some trendy internet cure? Sometimes the real issue hiding underneath the fatigue, the dizziness, the swollen ankles, and the brain fog is something far more ordinary. A medication that made sense 15 years ago, but has never been properly reevaluated since. That is the uncomfortable truth almost nobody talks about. And today, Dr. Jessica Parker wants to walk you through one of the most important health conversations older adults can have with their doctors. The conversation about whether some blood pressure medications may be quietly making life harder than it needs to be. Now, let me make something crystal clear before we go any further, because this matters enormously. This is not a video about stopping medication on your own. Do not suddenly stop any heart or blood pressure medicine without medical supervision. Some medications, especially beta blockers, can create dangerous rebound effects if they are stopped abruptly. What we are talking about today is something much smarter, much safer, and much more medically responsible. A careful medication review, a structured conversation, a process called deprescribing. Deprescribing does not mean rejecting medicine. It means asking whether an older prescription still belongs in your life, at your current age, in your current body, with your current goals and physiology. Because after 60, the body changes dramatically. Kidney function changes, liver metabolism changes, fluid handling changes, blood vessels stiffen. The nervous system responds differently. And a medication that felt perfectly tolerable at 50 can suddenly begin creating problems at 70 that nobody recognizes because the side effects often disguise themselves as aging itself. That is the trap. A person becomes more tired, a little weaker, a little slower. Their balance changes, their energy disappears faster, their exercise tolerance shrinks, their feet swell, their sleep worsens. Their thinking becomes foggier, and almost everyone around them responds the same way. Well, that is just what happens when you get older. Sometimes that is true, but sometimes it is not aging at all. Sometimes it is the medication. And once you understand that possibility, you start seeing older health very differently. I'm Dr. Jessica Parker, and over the years, I have worked with countless older adults who believed they were simply declining because of age, when in reality their bodies were struggling under medication regimens that had not been meaningfully reviewed in years. Not because their doctors were careless. Most doctors are trying to help. But medicine has a dangerous habit of becoming automatic. Once a prescription enters the system, it often stays there indefinitely unless somebody deliberately questions it later. That questioning almost never happens enough. So today we are going to talk about 3 extremely common blood pressure medications that older adults are often prescribed for years or even decades: Atenolol, hydrochlorothiazide, and amlodipine. We are going to talk about what they can do well, what they can quietly cost some people over time, and most importantly, how to recognize when your body may be telling you it is time for a medication review. Because your blood pressure number is not the whole story. The body underneath that number matters more. And by the end of this video, you may realize that some symptoms you blamed on getting older deserve a second look. Let's begin with Atenolol, sometimes sold under the brand name Tenormin. This medication belongs to a class called beta blockers, and for many years it became one of the standard tools doctors used for blood pressure and heart-related conditions. It slows the heart rate. It lowers blood pressure. On paper, it sounds simple. But the human body is not a paper chart. Atenolol works partly by reducing how aggressively the heart responds to stimulation. In some situations, that can absolutely be useful. But in older adults, especially those who have been taking it for many years, There is another side of the story that often gets overlooked. Your heart is supposed to respond dynamically to life. When you walk faster, your pulse should rise. When you climb stairs, your pulse should rise. When you carry groceries, your pulse should rise. When your muscles demand more oxygen, your heart is designed to adapt. Atenolol can flatten that response. And for some older adults, that flattening feels like life itself has lost its momentum. They describe it in surprisingly emotional language. I feel flat. I feel slowed down. I feel like I lost my spark. I cannot recover after a simple walk anymore. My body feels heavy all the time. The scary part is that most people never recognize those feelings as possible medication effects. They assume they simply crossed some invisible line into old age. But sometimes what they are experiencing is drug-induced exercise intolerance. That distinction matters. Because if your heart cannot respond normally to physical demand, even simple movement starts feeling harder than it should. Walking feels more exhausting. Stairs become discouraging. Recovery takes longer. And slowly, without realizing it, people begin shrinking their lives to match their lower energy. They stop taking walks. They stop gardening. They stop traveling. They stop moving the way they once did. Not because their body is incapable, but because the medication may be suppressing normal cardiovascular responsiveness. And there is another layer that deserves attention. Atenolol can also influence glucose metabolism in some people. Specifically, it may contribute to worsening insulin sensitivity in susceptible older adults. Now, let me be very careful here because nuance matters. This does not mean atenolol causes diabetes in everyone. It absolutely does not. But some adults over 60 already sit close to the edge of insulin resistance. Their fasting glucose slowly creeps upward over time. Their waistline changes. Their energy drops. Their recovery worsens. And if a medication nudges that metabolic picture further in the wrong direction, the effects can quietly accumulate over years. The danger is not dramatic overnight collapse. The danger is slow decline that nobody questions. One of the biggest mistakes people make is assuming that if a medication lowers a blood pressure number successfully, then the entire situation must automatically be good. But medicine is always a trade-off. The better question is not simply, is this lowering my blood pressure? The better question is, what is this doing to my whole body? Is it affecting energy, exercise tolerance, glucose control, circulation, daily function, mood? Those questions matter. If you are taking atenolol and your pulse is consistently very low, your energy has declined, your exercise capacity feels dramatically reduced, or your fasting glucose is drifting upward, those patterns deserve a real conversation with your doctor. Not panic, not self-diagnosis, a conversation. Before your appointment, write down 3 things: your resting pulse, your energy level during the day, and whether physical activity feels harder than it used to. Then ask directly, could atenolol be contributing to these symptoms, and is this still the best beta blocker for me at my age? That is how intelligent deprescribing begins, not emotionally, clinically. Now let's move to hydrochlorothiazide, often abbreviated as HCTZ. A lot of people think of this medication as a harmless little water pill. It sounds mild, it sounds routine, but routine is not the same thing as biologically neutral. HCTZ lowers blood pressure partly by helping the body eliminate excess sodium and water. And yes, in the right person, that can absolutely help. But every time the body loses fluid, it also risks losing critical minerals along with it. That matters more than most older adults realize. Potassium is not just a number on a lab report. It helps regulate heart rhythm, muscle contractions, and nerve signaling. When potassium drops too low, the body often begins whispering before it screams. People feel weak, they feel shaky, they get muscle cramps, they notice palpitations. They feel vaguely wrong but cannot explain why. And because the symptoms are subtle at first, they are often dismissed. Then there is magnesium, one of the most underappreciated minerals in the aging body. Low magnesium can contribute to fatigue, worsening sleep quality, muscle tension, cramping, and cardiovascular instability. Research increasingly suggests that chronic magnesium depletion may also play a role in vascular dysfunction over time. Now again, nuance matters here. This is not fear-mongering. This is physiology. A medication can help one system while gradually stressing another. That does not make the medication evil. It means the body is complex. There is another issue with HCTZ that many people never hear about. Thiazide diuretics have been associated in observational research with increased photosensitivity and a higher risk of certain non-melanoma skin cancers in some populations, likely because the medication increases the skin's sensitivity to ultraviolet light. That does not mean every person taking HCTZ is doomed to develop skin cancer. Absolutely not. But it does mean this medication has a larger biological footprint than many people realize. This is why older adults taking HCTZ should not simply have their blood pressure checked. They should also have periodic evaluation of electrolytes, kidney function, hydration status, rhythm symptoms, and overall tolerance. Because if a medication quietly shifts mineral balance for years, the body eventually notices, even if nobody else does. And this is where so many older adults get trapped psychologically. They assume fatigue is aging. They assume cramps are aging. They assume dizziness is aging. They assume weakness is aging. But age is not a diagnosis. Age is context. It means the body deserves closer attention, not less attention. Now let's talk about amlodipine, commonly known by the brand name Norvasc. This medication belongs to a class called calcium channel blockers, and in many cases it can lower blood pressure very effectively. But amlodipine has one extremely predictable side effect pattern that countless older adults quietly live with every day: swelling, especially around the ankles and lower legs. People notice their socks leaving deep marks. Their shoes feel tighter. Their ankles puff up by evening. Their legs feel heavy and uncomfortable. And once again, most people assume this is just part of aging or poor circulation. But in many cases, it is the medication itself. Amlodipine relaxes peripheral blood vessels. That relaxation changes pressure dynamics in the circulation, allowing fluid to move more easily into surrounding tissues, especially in gravity-dependent areas like the feet and ankles. And this is where something called the prescribing cascade often begins. One medication creates a side effect. Then another medication gets added to manage the side effect. Now the patient is taking more and more pills without anyone stepping back to ask the bigger question: is the original medication still the best fit? Sometimes the answer is yes. Sometimes it is not. That is why medicine should never become automatic. And this is one of the most important psychological traps older adults fall into. They slowly adapt to a lower quality of life without realizing how much they have adjusted. They stop walking as far because their legs feel heavy. They sit more because movement feels uncomfortable. They avoid outings because swelling worsens later in the day, and eventually they stop remembering what normal used to feel like. That adaptation is dangerous because it feels gradual and therefore invisible. I remember one patient very clearly. I will call her Eleanor. She was in her early 70s and had slowly stopped doing many of the things she loved. She used to walk every evening with her husband. She used to garden. She used to travel comfortably. But over time, her legs became swollen and heavy almost every afternoon. She blamed herself. She thought she was simply becoming frail. But when we reviewed her medications carefully, the pattern became obvious. The swelling closely followed the timing and dose of her amlodipine. Once her treatment plan was adjusted thoughtfully with supervision, something remarkable happened. Not magical, not dramatic overnight, but meaningful. The swelling improved. Walking became easier, her confidence returned, and perhaps most importantly, she stopped viewing herself as someone whose body was simply falling apart. That shift matters psychologically. Because once people believe decline is inevitable, they stop looking for solutions. Now, I want to pause for a moment because this is where many viewers misunderstand the entire point of a conversation like this. The goal is not to fear medication. The goal is not to reject modern medicine. The goal is smarter medicine, more individualized medicine, more frequently reviewed medicine. Because older adults are not just older versions of younger adults. They are biologically different in ways that matter enormously. Drug clearance changes, blood vessel behavior changes, kidney reserve changes, nervous system responsiveness changes, and treatments that worked beautifully decades ago may become less ideal over time. That is not anti-medicine. That is good medicine. So, how do you actually prepare for a proper medication review? First, bring data, not frustration alone. Write down your home blood pressure readings for a week. Include the time of day and how you felt physically when you took them. Write down your pulse. Write down symptoms: fatigue, dizziness, swelling, cramping, shortness of breath, exercise intolerance, palpitations, brain fog. The more specific you are, the more useful the appointment becomes. Second, bring a complete medication list including supplements and over-the-counter medications. Interactions matter more in older adults than most people realize. Third, ask 3 direct questions about every medication. Why am I still taking this? Is this dose still appropriate for me? Could any of my symptoms be medication-related rather than age-related? Those 3 questions alone can completely change the direction of a medical conversation. And if you are on Atenolol specifically, ask whether your energy changes, low pulse, or glucose patterns could be connected. If you are on HCTZ, ask about potassium, magnesium, hydration, and kidney function. If you are on amlodipine, ask directly whether swelling could be medication-related and whether another option might fit your physiology better. These are not unreasonable questions. They are intelligent questions. Now let me tell you something important that many older adults need to hear. You are not difficult for asking these questions. You are not being disrespectful. You are participating in your care. That matters. Because some older adults spend years quietly tolerating symptoms that could potentially improve simply because nobody ever revisited the medication plan thoughtfully enough. I remember another patient, a man I'll call Lester. He was in his late 70s and still worked part-time because he genuinely loved staying active. But slowly, he started feeling exhausted all the time. His legs felt heavy, his stamina collapsed, his blood pressure looked perfect on paper, and every concern he raised was dismissed as normal aging. That was the trap. When his medication regimen was finally reviewed carefully, the issue became clearer. His beta blocker was likely contributing to much of the fatigue and exercise limitation he had accepted as inevitable decline. With medical supervision, his treatment was adjusted gradually and thoughtfully, not recklessly, not suddenly. And over time, his energy improved dramatically. He started walking farther again, his mornings felt easier again, and most importantly, he stopped believing his body was simply doomed to deteriorate. That is what proper deprescribing can sometimes accomplish. Not miracles, reduced drag, improved function, better alignment between the treatment and the person receiving it. And honestly, that is what good medicine should always aim for. Because lowering a blood pressure number is not the only goal. The real goal is preserving life quality. Can the person walk comfortably, think clearly, sleep well, stay active, maintain balance, enjoy their day? If a medication improves a cuff reading while quietly making daily life worse, the conversation is not over. That is the deeper message here. Medicine is always about balancing benefits and costs, and after 60, those costs deserve regular reevaluation. So if this video sparked recognition in you, do not panic. Do not throw pills away. Do something much more powerful. Get curious. Write down the medication, write down the symptom, write down the question you want answered. Then bring those observations to your doctor and ask calmly, could this medication still be appropriate for me, or is it time for a review? That single question can open a completely different kind of healthcare conversation. And for some older adults, it can be the beginning of getting part of their life back. Because sometimes what people call aging is not aging at all. Sometimes it is physiology asking for a second look. And once you finally listen carefully, the body often tells the truth.